Thank you, sir, for your kind introduction. It's a very lengthy introduction for me also. So I'm just going to present our data and result. So it's the title of the study is whole exome sequencing and variant spectrum in children with suspected inherited renal tubular disorder from the East India Tubulopathy gene study.
If I may interrupt you already at this point, why are you not a co-author?
Sorry, hello.
Oh no, you have put yourself at the prominent position. I was just looking at the slide. I was looking for your name in the author list, but you have probably taken me out and put it very prominently at the bottom there. Is that?
It's nothing, sir, actually.
Okay, never mind. Go on. Sorry.
Okay, thank you. So the rationale for the study is tubulopathy. We know that tubulopathy is a heterogeneous disorder which are usually inherited in children, and identification of the genetic basis of it's able to establish a clear diagnosis, establish a specific workup, enable appropriate genetic counseling, and candidate screening at high risk relatives. And the next generation sequencing provide an opportunity for screening for underlying genetic mutation with a relatively quick turnover time. Unfortunately, there's a lack of data from Indian population in such spectrum. Our research objective was to describe phenotype-genotype data among a large cohort of children with suspected tubular disorder from Eastern India. So it's a prospective observational study. Children with suspected tubulopathy at any participating center in Eastern India underwent NGS to detect any relevant variant. So method was the whole exome sequencing by using NGS technology, Illumina technology, focusing on putative genes for tubular disorder. Pathogenicity was predicted as per American College of Medical Genetics and Genomic Criteria 2015. Pathogenic and likely pathogenic were considered as a significant variant. MLPA were used for confirmation of any suspected copy number variant, and Sanger sequencing was done for segregation. We use multiple database to search for prior confirmation of the novel variant. So now come to the result. So we have a total 77 patients, and the presentation median age of presentation, clinical presentation was 24 months, the range of 8.5 to 50 months. Male were majority, there's a 56, 73%, and major contribution of these studies from state of West Bengal. So most common phenotype was distal RTA, and there is a 25 followed by Bartter syndrome, 18 patient, and followed by proximal RTA, isolated hypophosphatemic rickets, and diabetes insipidus, and others. So we have a distal RTA as the most common phenotype. About 25 patients presented with this phenotype, and out of these 16 were genetically significant mutation is there. So about yield was 64%, and among them, 7 patients have some, we able to identify the comorbidities like sensorineural hearing loss, hemolytic anemia, etc. Next phenotype was a Bartter syndrome. Total patient was 18, and 14 out of 18 were have a significant genetic variant. There is a 78% is the L, and after the genetic diagnosis, we are able to do the revision of the diagnosis in 6 patients. So you can see there is a CFTR mutation in 4 patients. There is a cystic fibrosis gene, and 1 patient is a congenital secretory chloride diarrhea. So these two are a non-Bartter phenotype. There is a pseudo-Bartter phenotype. So genetic diagnosis is help to ruling out such pseudo-Bartter condition. Proximal RTA phenotype, we have 12 kids, and 9 out of 12, there is a 75% of got the genetic diagnosis, and we able to do revision of the genetic diagnosis in 3 patients presented with nephropathic cystinosis. So isolated hypophosphatemic rickets were 6 patients. So 5 out of 6 patients has a genetic diagnosis, and all of them have a FEX gene mutation. Then nephrogenic diabetes insipidus. So here is a 6 patient presented with this phenotype and have a 100% of positive significant mutation. So all of them has a significant mutation, but the diagnosis is revision of diagnosis in 2 patients. Those who are patient with the nephronothesis in 1 patient and 1 patient with distal tubular acidosis. So this could be the secondary causes of nephrogenic diabetes insipidus. So other phenotype patients were 4, and 2 out of them have positive significant genetic mutation, and all 2 has a new diagnosis with this mutation. So if we summarize our study, so total number of patients were 77, total number of variants which were found is 64, total number of pathogenic, that is a significant mutations, pathogenic and likely pathogenic variants were 55. Total number of children with confirmed genetic diagnosis is 54, that is 70%. Novel and pathogenic, likely pathogenic variants were 24%. So we can see here that we able to revise the diagnosis in 14 patients, that is 18% of our cohort. And it has a clinical impact on 24 patients regarding management and management and doing the diagnosis is about 1/3 of our cohort. So I'm just concluding from our study that NGS proved to be a useful tool for investigating childhood tubulopathy. It's showed a good L as well as a acceptable genotype-phenotype correlation and help in unmasking new diagnosis also. This will not only be helpful in management, but also screening of siblings and antenatal counseling. It also helpful in identifying novel variants, mostly due to the less number of genetic studies done in India. Okay, thank you so much. So we acknowledge our medicinal lab for helping us for doing this study.
Thank you, Shubhankar, for that quick presentation. So we'll have any questions for the attendees, you can put it into the chat box. And if Shubhankar, if you can like come out of it, and we can ask Dr. Bokanov to share his screen, and we'll go to his talk, and we'll have all the questions at the end. So now we come to the main part of the session, and as we all know that Dr. Detlef Bokanov needs no introduction. He is a professor at the University College London and a consultant in pediatric nephrology at Great Ormond Street Hospital, and a world expert in tubulopathy and electrolyte disorders. So Detlef, it's all yours. You are muted. Detlef, if you can unmute yourself.
Yeah, there we are. So good evening, and sorry for keeping you from dinner, which I understand is your time now. So we're gonna talk about clinical aspects now, mostly of tubulopathies. Hold on, there we are. So when we talk about kidney function, we usually mean actually glomerular function, specifically the glomerular filtration rate. That's almost synonymous. If anybody on the ward asks what's the kidney function, we usually mean the GFR. And this, I think, is also beautifully illustrated in this cartoon, which is found on the website of Kidney Research UK, which is the premier research charity for nephrology in the United Kingdom, where patients can then go and try to understand how the kidney works, and then they will come to this cartoon, and it shows how the dirty blood goes into the kidney, and then it goes to these super filters that clean out all those terrible wastes, which then come out in the ureter, and the beautiful, clean blue blood goes back into the body. Now, no mention of any tubules here at all, you notice. If you are interested in tubular function, obviously the world is completely different for you. You have this beautiful nephron, of which we have roughly 1 million or so in our kidney. And the glomerulus is really only the little appendix at the top of it. The rest is all tubule and where the money is. And especially from a tubular point of view, these super filters are actually super stupid because they throw out a lot of bath water and a lot of babies. Bath water it clearly is, because it's the extracellular fluid, the fluid that bathes, that surrounds all our cells. And we typically, as an adult, filter about 150 liters of this bath water. GFR, normal GFR, let's say 100 mLs per minute. So that's 6 liters per hour. So that's roughly 150 liters per day. And in those 150 liters of bath waters are a lot of babies. There is the equivalent of more than 1 kilogram of salt. There's hundreds of grams of sugars, amino acids, and so on and so on. And it's all thrown out by these super filters. And who needs to clean it up? Well, it's the tubules, of course. And if anything goes wrong in this cleaning up from what the glomerular throws out, then we get these tubulopathies. And I will specifically focus here on a few salt wasting tubulopathies. So this is a bit of an old-fashioned slide because it's from the time when we still had actually face-to-face seminars, and this is to illustrate how life would be without your tubules. A seminar would only be possible on the toilet, like these 5 gentlemen there, because you would constantly have to pee. If you're thinking about a normal bladder volume of 500 ml in an adult and you're peeing 150 liters a day, you would have to go to the toilet about 300 times. You can calculate that's how many times that is per hour. So you would, by the time you're back, you would have to go back. So message of this slide is your tubules are definitely a reason to be cheerful. And when we talk about the tubules, we typically divide it into these 4 functional segments: the proximal tubule, the thick ascending limb of Henle's loop, the distal convoluted tubule, and the collecting duct. And if something goes wrong in the reabsorption of salt, and again, the salt wasting tubulopathies is what I'm going to focus on here, you will generate a very specific electrolyte profile, a biochemical fingerprint, as I like to call it, and hence the title of the lecture, that will help you to make the proper diagnosis. So here's the first case. This was, in order to make it a little bit more entertaining for you, I've mixed these tubular segments so that you're not necessarily going in the order of the nephron. So this is a 5-year-old boy who was referred for persistent hypokalemia. That was first noted when he had a diarrheal illness at 1 year of age. At the time, it was ascribed to the diarrhea and never checked again. But now, because of speech delay, he had blood tests again. Why anybody would do blood tests for speech delay, I don't know, but he had them, and he had a potassium of 2.8. And then he had another blood test, and there was 2.7, and then he had another one, and there was 2.9. And so he was referred to us, and they had already done an aldosterone level, which was elevated. And yeah, so that's how he came to us. And on examination, he was completely fine, normally grown, normal blood pressure, unremarkable urine dip. And oops, here is his biochemistries. And in order to make it easier for you, I have highlighted in gray the abnormal numbers. So you can see that the fingerprint here, the electrolyte profile that is typical for this disorder, is the hypokalemic, hypochloramic metabolic alkalosis with hypomagnesemia. And those eagle-eyed amongst you will also note that there is a very low urinary calcium excretion, undetectable calcium levels there. So hypokalemic, hypochloramic metabolic alkalosis with hypomagnesemia and hypocalciuria. So as you are on a Zoom, or as we are on a Zoom, you're safe. Otherwise, if we were in the same room, I could pick on you and ask you questions. But this time you just only need to answer them in your head, and I will come to it. So which tubular segment do you think is affected? And what is the diagnosis? And the answer, of course, is that this is Gitelman syndrome. I'm sure most of you will have recognized that. Gitelman syndrome is a disorder of the distal convoluted tubule, as we will come to in the next slide. And I just wanted to go a little bit into more detail here about these electrolytes. So we're talking about salt wasting disorders. Yet, if you look at the fractional excretion of sodium, 0.4%, that's completely normal. So why is this a salt wasting disorder? And the answer is fractional excretion of sodium is not a good way of diagnosing salt wasting. The reason is that in steady state, you have to be in balance. The amount of sodium coming out in the urine must be equal to what's coming in. If you're persistently excreting more sodium than that's coming in, you will become progressively more hypovolemic, and then you will die of hypovolemic shock. And this normal sodium excretion, of course, is maintained because all kinds of compensatory mechanisms kick in, so that what's not reabsorbed in the distal convoluted tubule is reabsorbed in other segments. And one of those segments, of course, is the collecting duct, and I will come to that also in a slide, which is where it's then exchanged for potassium, for instance, and that's why you have this hypokalemia and high potassium excretion. The fractional excretion of chloride is a better way to look at these salt wasting disorders, because whether you're excreting sodium or potassium, both need to be accompanied by an anion. So the fractional excretion of chloride is typically high. And when we once looked at our Great Ormond Street cohort, we found that in all these salt wasting disorders at presentation, the fractional excretion of chloride was 0.5% or higher. Fractional excretion of magnesium is also elevated, which of course is consistent with the hypomagnesemia here, and that is a characteristic feature of Gitelman syndrome, just as is the hypocalciuria. So briefly to the physiology, so we are in the distal convoluted tubule, and on the basorolateral side, you have the engine that drives it all, the basolateral sodium potassium ATPase, which establishes the electrochemical gradient for sodium, which is then used by this apical sodium chloride cotransporter. That's the one that you will also inhibit with thiazides. And that's why Gitelman syndrome can be conceptualized as being on a maximum dose of a thiazide all the time. And the sodium that's coming in obviously is leaving here on the basolateral side through the sodium potassium ATPase. The chloride that's coming in is leaving through this basolateral chloride channel, CLC and KB. And this channel, as we will later see, is also expressed in the thick ascending limb. It's the cause of Bartter syndrome type 3, but because it's expressed here, this also explains why Bartter syndrome type 3 can sometimes mimic Gitelman syndrome and be clinically virtually indistinguishable. And then we have this magnesium channel here that is coupled into these whole transport processes. So that's why you get the hypomagnesemia in Gitelman syndrome. One word here about this basolateral potassium channel. So KCNJ10 is a gene that was associated with something called East syndrome, epilepsy, ataxia, sensory neural deafness, and tubulopathy. And the tubulopathy is indistinguishable from Gitelman syndrome. So it's the same features: hypokalemic, hypochloramic, metabolic alkalosis with hypomagnesemia and hypocalciuria. And it shows that this potassium channel is absolutely critical to maintain the activity of this basolateral sodium potassium ATPase. And if there is not enough potassium supplied by this channel, this one doesn't work. And then of course, you're not establishing the electrochemical gradient for the sodium, so this one doesn't work. And very recently has been a publication now where we show that KCNJ16, another potassium channel, actually forms heteromeres with KCNJ10, and mutations in this channel can also cause a phenocopy of Gitelman syndrome, but with associated sensory neural deafness because it's also expressed in DNA. And then here we come to this fingerprint, the biochemical fingerprint of hypokalemic, hypochloramic metabolic alkalosis. And this is predominantly because of the activated sodium reabsorption here in the collecting duct. This is mediated by aldosterone, and we saw at the beginning that his aldosterone levels were elevated because of the volume contraction from the salt wasting. And this aldosterone, when it binds to the mineralocorticoid receptor, will induce the expression of this channel here on the apical membrane. And because of the electrochemical gradient that, again, like we saw upstream, is established by the basal-level sodium-potassium ATPase, sodium that's not reabsorbed up here will now rush through this epithelial sodium channel, but the limiting factor for that is the voltage. If you're reabsorbing lots of positive charges, then that will impair further transport of sodium. And this voltage is mediated here by if you reabsorb, for each sodium you reabsorb, you can either secrete potassium through this potassium channel KCNJ1 or ROMK, and that's how you get hypokalemia, or by secretion of protons in the neighboring intercalated cells, and that's how you get the metabolic alkalosis. So this hypokalemic metabolic alkalosis, which I call the fingerprint of aldosterone, really is generated down here in the collecting duct and is mediated by aldosterone. Okay, we're moving on to another case. So this is a 6-day-old girl, full-term, normal delivery, birth weight 2.66 kilograms. She was breastfed, and she is brought to the A&E because the parents are worried about her. And as an experienced pediatrician, you take one look at this baby and you know this baby is in trouble. She has lost a considerable amount of weight. Her blood pressure is lowish. She has poor peripheral circulation. She is hypovolemic. And you get even more worried, of course, once you get the blood test back. So mild hyponatremia, an impressive potassium, as I think you will agree. So we have hyperkalemia, and then we have acidosis. So it's pretty much the opposite of the fingerprint that we saw before. Before we had hypokalemic alkalosis, now we have hyperkalemic acidosis, and we already have an elevated creatinine, 86 micromoles, so probably reflecting the severe hypovolemia. So what's your differential diagnosis here? Again, just do it in your head, and then you can see if you did it right or not. Is this dehydration from gastrointestinal losses with acute renal failure? Is this congenital adrenal hyperplasia? Or is this pseudohypoaldosteronism? And this is actually a bit of a trick question because it could be a really, I think, any of these three. And we will need a few more lab tests later on, which will help you. Which part of the tubule is most affected? That is a straightforward question. Is it proximal tubule? Is it thick ascending limb? Is it distal convoluted tubule? Is it the collecting duct? And the answer, of course, is it's the collecting duct. So here, this the biochemistries in a bit more detail. Now, this is a salt wasting disorder where you actually have an increased FeNA. And this is why you're so worried about this baby, because this baby is persistently excreting more sodium than it's coming in. And if you're not giving her sodium anytime soon, she will die in front of you of hypovolemic shock. And you don't need to calculate fractional excretions of potassium or the transtubular potassium gradient. It doesn't really matter. If you have a plasma potassium of 10.7, you want to have as much potassium in the urine as possible. And yet these kidneys are hardly excreting any potassium. So you know there's a problem. And potassium secretion obviously is in the collecting duct. So this is why the problem is there. And then here we have the renin and aldosterone levels, which immediately show that this is not congenital adrenal hyperplasia. There you would not be able to make aldosterone. Here you see the adrenals are making aldosterone like there's no tomorrow because of this severe hypovolemia with these dramatically elevated renin levels, of course, also, but the kidneys are unable to respond to it. So we're coming back to this cartoon that I showed you before, but in the Gitelman syndrome. In the context, we had enhanced sodium absorption here. In this disorder, pseudohypoaldosteronism type 1, you have impaired reabsorption. So there are two forms of pseudohypoaldosteronism type 1. There is the dominant form, which is due to mutations in the gene encoding the mineralocorticoid receptor. And then you have the severe recessive form, which is what this girl had, which is mutations here in the epithelial sodium channel ENaC. So she cannot reabsorb sodium there, and because she's not reabsorbing sodium, she's not creating the voltage gradient that would allow the secretion of potassium, and that would facilitate the secretion of protons, and that's why you get the hyperkalemic acidosis. And for those of you who are not familiar with the assessment of potassium excretion in the urine, so fractional excretion of potassium, you're all familiar with fractional excretion, so I don't need to explain that to you. Hardcore physiologists do not like the concept of a fractional excretion of potassium, and that's because fractional excretion is supposed to be used for those substances that are filtered and reabsorbed. Potassium is filtered, reabsorbed, and secreted. So you can have fractional excretions greater than 100%, which of course is something that physiologists do not like at all. Nevertheless, in clinical practice, I think it works just as well. And if it's less than 10%, obviously you have very little aldosterone activity, very little potassium secretion. If it's greater than 30%, then you have high potassium excretion. But in some disorders, like we will see, I think later, Bartter syndrome, you can actually excrete 100%, more than exceed 100%. And the trans-tubular potassium gradient is what physiologists then dreamt up instead of the fractional excretion, and it is supposedly specific for potassium secretion in the collecting duct, and that's based on the idea that the concentration of potassium in the urine can only change because of two factors. One is you secrete potassium into the collecting duct, so you increase the concentration by secretion, and the other one is that you extract water and thus increase the concentration. And the water extraction obviously is best assessed by the osmolality. So it's calculated just like the fractional excretion, but you use osmolality instead. And if it's less than 4, that would be very low aldosterone activity, very low potassium secretion there. If it's greater than 12, then it's very high. These numbers are, of course, sort of arbitrary. If it's 5 and somebody with a potassium of 10, then that's still very low. And if you have a potassium of 2.8 and you still have a TTKG of 10, then it's still high. So it's don't take these numbers religiously. They're more a rough guide. So here's case number 3. This is, I'm sure all of you will recognize that pretty immediately. This is a premature baby. Pregnancy was complicated by polyhydramnios. Mom underwent 3 amniocentesis where liters of fluid are being taken off. And during the last one, she experiences premature contractions, and the baby gets born prematurely, weighs 1.75 kilogram, is immediately a problem because of large urine output, also has some gastroesophageal reflux, and at about 2 weeks of age is then transferred over to us. And on examination, he's relatively stable, has hardly gained any weight, has low blood pressure. And here is the electrolyte profile. And again, you will recognize the fingerprint of aldosterone, the hypokalemic, hypochloramic, metabolic alkalosis. There's some hypercalcemia, presumably from dehydration. I didn't give you an albumin here. The albumin was elevated. And there's again also some acute kidney injury here with a creatinine of 96 micromoles per liter, again reflecting the dehydration. So what's the most likely diagnosis? Is this dehydration from gastrointestinal losses? Is this Bartter syndrome? Is this Fanconi syndrome? Is this Gitelman syndrome? Is this cystic fibrosis? And which tubular segment is affected? And the answer, of course, is that this is classic antenatal Bartter syndrome, which is a disorder of the thick ascending limb. And again, going a bit more into the details of the biochemistries. So here, fractional excretion of sodium is what's usually considered borderline normal, but of course also the GFR was quite markedly impaired. So this again is the steady state of what's going on here. You see a fractional excretion of potassium that's higher than 100%. So the tubules are going full blast at excreting of secreting potassium, and of course the fractional excretion of chloride is also markedly elevated, again consistent with the salt wasting disorder. And then there's hypercalciuria. So the hypokalemic, hypochloramic metabolic alkalosis with hypercalciuria is classic for antenatal Bartter syndrome. And as I said before, this is a disorder of the thick ascending limb. And again, on the basolateral side, you have the engine that drives it all, that establishes the electrochemical gradient for sodium, which is then used here by the apical sodium potassium 2-chloride cotransporter NKCC2 in order to bring sodium, potassium, and 2-chloride in. The sodium leaves, of course, here through the sodium potassium ATPase. And this transporter is the one that you inhibit with loop diuretics. And this is why you can conceptualize Bartter syndrome, or antenatal Bartter syndrome at least, as being on a maximum infusion of a loop diuretic. And this was also the gene encoding this transporter was the first gene identified as causing Bartter syndrome. The potassium that's coming in recycles. It goes straight back out through this potassium channel, KCNJ1 or ROMK, two different names for the same channel. And the gene encoding this potassium channel was the second gene to be identified as a cause of Bartter syndrome. And that highlights, of course, the importance of this channel. Just as we saw before with Gitelman syndrome, the basolateral potassium channel that was providing a steady supply of potassium to the pump, this channel provides a steady supply of potassium here for this transporter. And if you don't have this supply, the transporter cannot function. The chloride that's coming in through here leaves on the basolateral side through the chloride channel ClCNKB, and probably also a little bit through the sister channel A. And the gene encoding ClCNKB was the third gene associated with Bartter syndrome. It needs a subunit called Bartin, encoded by a gene called BSND, and that is the fourth gene that was identified as causing Bartter syndrome. Now, one little aspect here, you may of course ask yourself, why would nature make it so difficult, so unnecessarily complicated to have a transporter that brings in potassium here only to have it leak back out? Isn't that just complicated, and actually, as the Bartter syndrome type 2 shows, adds potential for more things going wrong? And the answer is, this is actually a very nifty solution that evolution has come up with, because this transporter here is electroneutral. It has 2 positive, 2 negative charges. If you're now leaking the potassium back out, it all of a sudden becomes electrogenic. And now you have a transepithelial voltage gradient, more positive charges on the apical side than on the basolateral side. And this transepithelial voltage gradient drives the paracellular reabsorption of cations, specifically calcium, magnesium, but also a considerable amount of sodium. And this is why these patients have also hypercalciuria and nephrocalcinosis, because this paracellular transport is impaired. Moving on to the fourth case. So this is a 4-year-old boy who was referred for poor growth and persistent proteinuria. He is on the smaller side, but otherwise normal blood pressure, and his urine dip is notable for glucose positive. There's some protein in there, but he seems to be able to acidify his urine to some degree. And here we come to another kind of fingerprint. Here we now have hypokalemic, hyperchloramic metabolic acidosis. So this is the third kind of fingerprint that we are seeing here. And then here's some additional abnormalities. Here's hypophosphatemia. And then we already spoke about the glucose in the urine. There's also some albumin in the urine. So which part of the tubule is most affected? This is the proximal tubule. This is the thick ascending limb of Henle's loop. This is distal convolute tubule or the collecting duct. And this, of course, is the proximal tubule. This is Fanconi syndrome. I'm sorry, renal Fanconi syndrome. The proximal tubule is the only segment in the tubule that is handling glucose and phosphate. So if you have wasting of those substances, then the proximal tubule must be affected. And the most sensitive marker for proximal tubular dysfunction actually is the low molecular weight proteins. Here and at Great Ormond Street, we do the retinol binding protein, and it's exquisitely sensitive. It really goes up by 3, 4, sometimes 5 orders of magnitude. And you can see that here, it's 48 milligrams when it should be something like 40 milligrams. So it's 1,000-fold increased. And again, the proximal tubule is where you're supposed to reabsorb 60 to 70% of your filtered sodium. But look at the fractional excretion of sodium. It's less than 1%. It's normal. And again, of course, means in steady state, what's coming out in the urine must be equal to what's going in. Otherwise, the patient would not be alive anymore. And when you have proximal tubular dysfunction, you never have completed dysfunction. It's always an impairment, and you have the other segments that can also compensate. And this compensation is reflected then, of course, also in the hypokalemia. So that's when in the collecting duct, the sodium is rescued in exchange for potassium, but some potassium, of course, is also reabsorbed in the proximal tubule, and if that's not working properly, that will also contribute to the potassium wasting. And then bicarbonate is exclusively reabsorbed, well, not exclusively, but mostly reabsorbed. 90% or so is reabsorbed in the proximal tubule. So you get bicarbonate wasting. And I'm seeing I'm discrepant to what I wrote before about pH 6. I think I put in here 5.5 because that's usually what we say is the limit of normal urinary acidification. So this is to highlight that this boy actually can acidify the urine normally. So his distal acidification is intact, and the acidosis is purely based on bicarbonate wasting. Calcium is reabsorbed in the proximal tubule, so you get hypercalciuria. You have the phosphate wasting. And albumin, this is, I think, a very important point. Albumin is sometimes considered to be a marker for glomerular dysfunction, but it really is not. There's a considerable amount of albumin that is physiologically filtered and reabsorbed in the proximal tubule. How much the experts are debating, but it's probably around 1 to 4 grams per day. So if you have proximal tubular dysfunction, it's not unusual to have a significant amount of albumin in your urine. And this kind of urine albumin creatinine ratio around 100 is typically what we see in our patients with proximal tubular dysfunction. Oops, there we are. So this is renal Fanconi syndrome, and the full-blown renal Fanconi syndrome, the full-blown proximal tubular function, you will have glycosuria, you will have phosphaturia, you will have acidosis from the bicarbonate wasting, will have low molecular weight proteinuria, but that includes to some degree albumin. You will have hypercalciuria, aminoaciduria, because you're not 1-alpha hydroxylating your vitamin D, you will also have rickets, and because it's salt wasting, you will also have low blood pressure, and then we talked about the hypokalemia. So briefly to the physiology, again, the engine that drives it all is the basolateral sodium potassium ATPase, establishing the electrochemical gradient for sodium, which is then used, for instance, for sodium exchange here with hydrogen. And this is how you're reabsorbing bicarbonate, as I'm sure you're all familiar with, or for co-transport with sodium, for instance, sodium phosphate co-transport or sodium glucose co-transport. And then as you remove those solutes from the tubular lumen, you also create an osmotic gradient for the reabsorption paracellular, for instance, here of calcium. So that's, if you're not reabsorbing enough, then you're also not reabsorbing calcium there, and that's how you get the hypercalciuria. Sorry, I just going to go back one more time because I want to highlight the fingerprint here. So the hypokalemic, hyperchloremic acidosis, that's the fingerprint of renal tubular acidosis, whether it's proximal or distal, they're both characterized by this fingerprint, hypokalemic, hyperchloremic metabolic acidosis. And I'm coming to the last case so that I'm not keeping you from dinner for too long. So this is an 1.5-year-old boy, failure to thrive, history of severe gastroesophageal reflux, chronic constipation, who comes to us and, well, he has a little bit of protein in his urine, but otherwise nice concentrated urine. And here are the biochemistries. And he has a fingerprint that by now you should be familiar with, hypokalemic, hyperchloremic metabolic alkalosis, the fingerprint of aldosterone. He has normal magnesium, his elevated renin aldosterone. And the reason why he came to us was suspicion of Bartter syndrome. So what is the most likely diagnosis? Is this Bartter syndrome? Is this Fanconi syndrome? Is this Gitelman syndrome? Or is this congenital chloride diarrhea? And in order to make that distinction, we actually need to look at these biochemistries in a bit more detail. So he does have the hypokalemic, hypochloremic metabolic alkalosis that you would also expect to find in Bartter syndrome, and which is why he was referred to us as such. But this is now where the fractional excretion of chloride becomes really, really helpful. I told you before, the fractional excretion of sodium is not a good indicator because in steady state, it must match what's coming in. And you can see that's pretty similar to what we, for instance, saw before in Gitelman syndrome. And you have elevated potassium excretion, dramatically upregulated, but now we have virtually no chloride excretion at all. And that excludes a renal salt wasting disorder. This is not renal salt loss. And at the time, I thought it was just the severe gastroesophageal reflux that he was having. But with time, actually, it became clear that the chloride was in the stool and that this was a case of congenital chloride diarrhea. And because this boy has then maximally upregulated salt reabsorption in all segments, including in the proximal tubule, it's why they get hypocalciuria, because as you reabsorb all the salt in the proximal tubule, the calcium follows along passively, as we've seen before. So this is, I think, also nicely relates to the previous presentation that we had about the genetic testing and tubulopathies. These kind of extra renal salt losses in cystic fibrosis or in congenital chloride diarrhea will create the same exact biochemical fingerprint as Bartter and Gitelman syndrome, the hypokalemic, hypochloremic alkalosis, the fingerprint of aldosterone, as I called it before. And that's, of course, because they have elevated aldosterone, but it's not because of renal salt loss and hypovolemia, but because of extra renal salt loss and hypovolemia. And the way to distinguish between them is by looking at the fractional excretion of chloride. And I'm not going to go through this slide. I sent the slides to Rajiv, so you can take them home, but this would be sort of a little tick box list of how you can be a Sherlock Holmes yourself and fingerprint the salt waster. And with that, I'm going to stop. Thank you very much.
So thank you very much. And as I said, again, in all that, how you make this difficult thing simple.
They are simple. That's the
yeah, but when I listen to you, it is simple. But then again, it becomes difficult when you are not around. We will go for any questions. Any of the panelists have any questions?
We can take them, I think, after the questions in the chat box.
Yeah. Let me see.
I see some questions.
One question was that, like, since many of these children are on IV fluid, does that interfere with us looking at fractional excretion of sodium, potassium, etc.?
Yes, of course. I mean, whatever, if you're giving them lots of salt, then they will also excrete lots of salt. Again, you need to stay in balance. What goes in must come out. So if you take also a Gittelman or a Barter patient and you've started them on sodium supplements, for instance, their fractional excretion of sodium will go up because they don't have to use as much compensatory mechanism to reabsorb sodium. Because in the end, what goes in must come out. That's the idea of homeostasis. That's the idea of our tubules providing balance. So if you give them lots of water or lots of salt or lots of potassium or whatever, those will also increase in the urine. So that will definitely affect the interpretation of these biochemistries.
So should we stop fluid before doing it, or just keep that in
Ideally,
mind?
you always get the initial native urine. I think that's usually the best thing. If you can get it before you interfere, or otherwise, yes. If you, I mean, it depends obviously on how well the patient is. But a Gittelman patient, for instance, you would usually not provide IV fluids to. So ideally, you will stop everything and then do your diagnostic biochemistries if you haven't done it when the patient came in.
There was another question, and this is, and I also had a similar question. This particular question is like, does TTKG works in newborn? And my overall question is that many times I get referral from NICU about tubular disorders, like a low sodium, low potassium. So, and even say in preterms, suspecting renal tubular acidosis and Barter. So first question is like, does TTKG work in newborn? And secondly, like all these parameters, should we be making much interpretation in the NICU in a critical baby, or we should be just waiting?
So TTKG and fractional excretion of potassium, of course, it works also in a neonate, and it works in a premature baby. I think all these urinary biochemistries always need to be interpreted in the context of the plasma biochemistries. If you have a high TTKG but a normal potassium, it doesn't mean anything. If you have a low TTKG and a normal potassium, it doesn't really mean anything. It's only if the potassium is really high and then you have a very low TTKG that you know the tubule is not doing what it's supposed to do. So the question when you interpret these biochemistries is always, what would you expect a normal healthy tubule to do in the clinical context? I hope that makes some sense.
No, my question was particularly like, we have seen number of times children with in NICU with the sepsis, etc., having abnormal electrolytes, maybe suggesting renal tubular acidosis, maybe suggesting some of these tubulopathies, and then we send off genetic tests, but then they come back as normal, and usually with time, like in a month or so, everything just disappears. So if we are getting a referral of this sort of cases from in a critical baby, should we be doing all these tests, or should we be just going for like supportive care till the child baby gets stabilizes?
Yeah, it's difficult to talk about this in general terms without an example of what you could do. I think with experience, you get a pretty good idea about whether this fits the phenotype that you usually expect to see in Bartter syndrome or something like that. And if it does fit, even in the critically baby, I think it's perfectly fine. But if you have acidosis and you see the urine pH is 5.5, well, then there's no point in thinking about distal tubular acidosis, because the baby seems to be able to acidify the urine. So, and the acidosis is due to other causes. And if you see acidosis with evidence of bicarbonate wasting, but there's no glycosuria, there's no phosphaturia, there's no low molecular weight proteinuria, well, then it's unlikely to be a renal Fanconi syndrome, and it's unlikely to be a tubulopathy, and the bicarbonate loss is due to some other causes. So I think you always need to look at the picture overall And then again, as I said before, interpret the urine biochemistries in the context of what's going on in the plasma.
Another question was about hypocalciuria. Does it also have any cutoff value as per age, or is it a fixed one?
I think there are some people who also have cutoff values for that. But I mean, if you see a calcium that's below the measurement threshold like we have, then that would be usually good enough for me. So if it's at the lower end of the range that's usually quoted, I think that's fine. But I'm sure there are some people out there who have defined values for hypocalciuria. It's very, very difficult to always have these clear cutoff values where you say, well, if it's above 0.1 millimole per millimole creatinine, then it's normal. And if it's below, it's hypocalciuria. If it's 0.99, it's hypocalciuria. But if it's 0.101, then it's normal calcium. There's never that kind of clear distinction. So I think you have to always use your judgment a little bit.
And another question was like, do you have any preference for 24-hour urine collection, or just a spot urine will suffice? And if a spot, any particular time?
With regards to calcium, or in general?
Yeah, in general.
No, I mean, I could have and could think of reasons, but I mean, usually the patients come to clinic at whatever time you gave them an appointment. So that's the time when I get the urine. If I can, in older toilet-trained children, I often try to get a 24-hour urine, sort of a confirmation as of the spot urine. But in the vast majority of cases, I personally just use the spot urines because it's just so much easier.
I think we have covered most of the question except from Dr. Sumanta Raut. And Dr. Sumanta Raut is in our panel only. So I'll introduce Dr. Sumanta. He has recently, it's almost more than a year, come back from AIIMS, New Delhi, after doing his DM. DM is something equal to the CCT that we do in pediatric nephrology. And he has got multiple questions and bubbling with knowledge. So Sumanta, you can ask your questions. I think there are 4 or 5 questions, and I'm sure Detlef will answer you.
Thank you, sir. Hi, sir. Hi, Dr. Detlef. Actually, sir, a little bit small queries. First thing is, we usually do a blood anion gap in case of RTA and urine chloride in case of alkalosis like Barter or gentleman. What is the answer in reverse? Means what will be the blood anion gap if we do in case of Barter, and what will be the urine chloride if we do in case of RTA? Because many a time the child comes with a bicarb of 21, or the next day the bicarb is 26. It's a varying type, and we also know that some of the cystinosis childs are initially comes with a contraction alkalosis instead of acidosis. So what will be that value, around approximate value?
So I'm not quite sure if I understood the question correctly, but in tubulopathies, you will always have a normal anion gap. Okay, because the anion gap is created by provision of extra acid, whether it's lactate or whether it's these metabolic disorders, any kind of other acid metabolite that's accumulating. So in tubulopathies, the anion gap should always be normal. Does it answer your question, or did I misunderstand you?
Right, sir. I got your point, sir. So in case of Barter syndrome, usually the blood chloride is low. So is there a possibility of a high blood anion gap because the chloride is low?
Well, the chloride is low because the bicarb is usually high. I mean, you get the hypochloramic metabolic alkalosis. So if you add them up together, you still get a normal anion gap usually.
Okay, sir. Thanks. So the next question is, usually if we find a distal RTA, we usually screen for deafness and usually for ovalocytosis in our Asian population. So somebody has missed it during the workup, send a genetic test, and the genetic test report came as anion exchanger defect. Now the physician went back and did a peripheral smear and found ovulocytosis. Is this example of reverse phenotyping, or is this something like a missed phenotyping earlier?
It's both. Because it was missed earlier, it was only detected by reverse phenotyping.
Okay, sir. Thank you.
Sumanta, what about that? I think that's a good question you've asked, about classic water and nephrocalcinosis.
Yes, sir. Usually in case of classic butter, there is hypercalciuria, but usually there is no nephrocalcinosis found. Usually, sir. Is the reason is the polyuria or the huge urine volume?
So classic Bartter usually refers to Bartter syndrome type 3 due to mutations in the basolateral chloride channel. And according to the textbook, these patients usually have normal calciuria. And that's because they still are able to some degree to establish this voltage gradient, this transepithelial voltage gradient, because their sodium potassium 2 chloride transporter and the potassium channel are still working. So they can still establish this transtubular voltage gradient that I discussed in this cartoon of Bartter syndrome. Maybe I just go there. There we are. So classic Bartter syndrome would be due to mutations here in this channel encoding this basolateral chloride channel. But this couple here, the sodium potassium 2 chloride co-transporter and the potassium channel are still working. So they can still establish the transepithelial voltage gradient that allows calcium and magnesium and sodium reabsorption. So according to the textbook, patients with Bartter syndrome type 3 have normal calciuria, but clearly there are some patients who also have hypercalciuria. And of course, if no chloride at all is transported here, then these can't also not really work, because this transporter only works if chloride comes along with it. And then some patients actually have hypocalciuria, and that's because this chloride channel, as I showed you at the very beginning, is also expressed in the distal convoluted tubule. And for whatever reason, when patients get older with Bartter syndrome, they sometimes seem to not mind so much about the loss of chloride channel here in the thick ascending limb, presumably because the other channel A can take over some of the function. And then they have a Gittelman-like phenotype with hypocalciuria. So with Bartter syndrome type 3, textbook says normal calciuria, but some have hypercalciuria, even nephrocalcinosis, and some have hypocalciuria. So you can see everything.
Okay, sir, got the point. So my last question is, what is the reason of development of rickets in case of distal RTA? Usually development of rickets requires some phosphate excretion like this, but in distal RTA without proximal dysfunction, they usually have normal phosphate excretion. So any reason of development of rickets in distal RTA?
Yeah, the biggest buffer system for acid in your body is your bone. Your bone contains hydroxyapatite, which is an alkali. So if you are acidotic, then the acid will dissolve the hydroxyapatite. It will dissolve your bone, which is also the reason why patients with distal RTA get hypercalciuria and nephrocalcinosis, because they use their bone as a buffer for the acid. They dissolve their bone. And a very nice experiment to do at home if you have access to hydrochloric acid is to put a chicken bone after your dinner into hydrochloric acid, and you will see some fizzing. And at the end, after a little while, there's nothing left over except for the collagenous part. But so it will be a little bit of rubber left over. All the structural part of the bone has completely dissolved because acid dissolves bone. And that's what's happening in distal RTA. So you're dissolving your bones, the calcium comes out, and the patient gets weak bones and rickets.
Okay, thank you, sir. Thank you very much for all the nice explanation. Thank you.
Good.
So thanks, Detlef. There was one more question from do you have hypercalciuria in proximal RTA? Can you have hypercalciuria even in proximal RTA?
So proximal RTA occurs essentially only in the context of a generalized renal Fanconi syndrome, of a generalized proximal tubular function, and hypercalciuria is part of that. There is this exceedingly rare disorder of proximal RTA with IF abnormalities, which is just the basolateral sodium bicarbonate co-transporter that's affected. But I would I'm not sure at this point, but I would expect that they also have hypercalciuria, because again, their sodium hydrogen exchange will be affected if you can't take the bicarbonate on the other side out. So I would expect that they have decreased sodium transport in the proximal tubule, and therefore also will create not enough osmotic gradient for the calcium reabsorption. But I'm not completely sure about that. I would have to look that up.
No, my question was about these generalized proximal tubulopathies. So
Yes.
can you have hypercalciuria in them, like in
Yes,
Fanconi?
yes, that's part. Yes, absolutely, that's part of the disorder. Calcium is reabsorbed paracellularly in the proximal tubule, and as you reabsorb all these solutes, you make the tubular lumen hypotonic, and that creates the driving gradient then for the calcium to come.
But the chances of nephrocalcinosis is low, is it?
It's low. It is indeed low, and that's probably because they have quite a bit of because they have such polyuria.
What about Dent syndrome in relation to this this topic we are discussing?
Yeah, they do get
dysfunction.
that's a selective proximal tubulopathy. They don't have generalized dysfunction. Nephrocalcinosis is usually a late feature in these patients. In the beginning, often they don't even notice the hypercalciuria, but it becomes prominent later on. So yeah, I guess it shows the variability in the phenotype of these proximal tubulopathies.
I had a couple of questions. Can I, Rajiv?
Yes, please. Yes.
When you are treating the really bad antenatal Barters, we had one patient in this study who presented with severe hypercalciuria and loads of stones, who we found out had a ROMKey gene defect only after the study. And again, not just in this patient, but in all the others with antenatal Bartter syndrome with massive hypercalciuria, the options for treatment, does that deal with the hypercalciuria and the stones? Can you improve that in any way?
Not really.
Yeah.
I mean, the things that you will usually do, and I had this discussion with Rajiv a couple of times. Some people give thiazides to reduce the hypercalciuria. I personally do not think that's a good idea, because one of the reasons why these patients survive actually is because they have upregulated salt reabsorption in the other segments, and they typically actually have quite massive hypertrophy of the distal convoluted tubule as a segment to rescue all that salt that's not reabsorbed in the thick ascending limb. So if you inhibit that with a thiazide, you put them at a much higher risk of hypovolemia, I would think. So especially if they get diarrhea, vomiting, and some extrarenal salt losses, then you not only have a genetic knockout of the thick ascending limb, you also have a pharmacological knockout of the DCT, and I would be very worried about acute hypovolemia. So I personally do not use thiazides in these patients. You also don't really want to give them citrate because they're already alkalotic. You make them more alkalotic. Although with ROMK, sometimes you are not that severely alkalotic, so you can consider that. But if you actually check the urine in these patients, they typically have quite high citrate excretion in the urine anyway. So the question is, what are you going to do if you give them additional citrate? So there is very little treatment options really that you have for these patients, in my opinion.
Yeah, this is exactly what happened in our patient. Even before the genetic diagnosis came to us, because of the severe hypercalciuria, we had already started a little bit of thiazide, and that was the first time he had a full-blown Barters-like presentation with hypokalemia and hyponatremia. So obviously it was stopped, but now we are puzzled as to how to treat him further.
Yeah. There are a couple of, I mean, fortunately, again, it's very rare. And I think that's typically because they are so polyuric that the stone formation is rare. But we also have one or two with antenatal Bartter syndrome who develop stones. And yeah, there's nothing really that you have that you could make them better.
The other question is that, again, part of the study, we had a girl with very classical hypophosphatemic rickets, both phenotypically and biochemically. And when we did her exome sequencing, there was actually nothing wrong. But because we were convinced, yes, we couldn't find any. It was reported. Actually, there was a report of the FSGS gene, which had, nothing to do with the phenotype.
Yeah.
But because we were convinced that there was something happening, we talked to Anil, actually, who's one of our colleagues in Bangalore who has an interest in nephrogenetics. And he went back and talked to MedGenome, and they did some further studies, which then found a massive deletion in the PEX gene, a massive deletion which had not been picked up. So the question really is that NGS, obviously, we are not going to pick up everything by NGS. What should be, is there like a flow of things we should think of? If we have something that we really suspect is due to a genetic condition, NGS is negative, is there a flow of different tests we should go to, or does it depend completely on each condition?
So this is a really good point that you're making. And actually, next week, we have a seminar here where we will present 3 cases of hypophosphatemic rickets, which we have picked up by whole genome sequencing. So they were all negative on the traditional genetic testing. And by whole genome sequencing, we found a deletion and inversion of a segment actually in there. One had a deletion, one had an inversion of a segment, and one had a intronic variant that created a new splice variant. So I think your point beautifully illustrates that if you do get a negative genetic test, it doesn't exclude the diagnosis. It just shows that you haven't proven it genetically, but the diagnosis is still correct. Second, if you have a strong clinical suspicion that this is the gene, this is the diagnosis, and you have a negative genetic test, then if you can, pursue whatever other options you have, like you did, and then they found this deletion. So genetic testing is not a foolproof way of diagnosing. If you do get a diagnosis, wonderful. But of course, you also have false negatives, just as you have false positives. Like any other diagnostic test we do, they always are, they have some false positives and some false negatives.
So many of our companies here are offering whole exome sequencing for the same price as NGS. But would whole exome
sorry, what do you mean by NGS?
The
whole
clinical
exome
targeted sequencing.
Okay. So it's like a panel, like panel sequencing. Yeah.
So, but would copy number variations show up in whole exome sequencing?
So yes.
Deletions and duplications and things, they would.
Yeah, and the algorithms to detect them are a lot better. You always have a with the massively parallel sequencing or next generation sequencing or whatever you're going to call it. Massively parallel is quite nice here as an expression because it shows that you sequence it multiple times. You get multiple reads. That's what we also call as the sequence depth or the read depth. And in exome sequencing, you would expect a read depth usually of like 100 times, so that you have sequenced this part of the gene at least 100 times. Now, if you have 100 times, 100 times, 100 times, and all of a sudden it drops to 50, 50, 50, 50, and then it goes back up to 100, then that's highly suspicious that there is a heterozygous loss of one copy. And the algorithms that the labs nowadays use to detect that have gotten really very good. So in the beginning, when we started with this next generation sequencing, that was not part of the analysis. But nowadays, they are really have gotten very good at detecting deletions in there as well, or copy number variants.
Thanks, Detlef. It's a really good lecture and good discussion, and we are not missing our dinner at all.
Well, enjoy it now. Thank you.
One more thing. No, sorry, one more. Last one. It's about, like when we were writing up this paper, we had this discussion about like urinary electrolytes in many of our places in India are not being measured. I mean, not in the bigger centers, but at least in some smaller centers. So is it anything different measuring urinary electrolyte and serum electrolytes?
No, no. They usually put it on the same analyzer, but a lot of labs have some scruples about putting urine into their blood analyzer. But it's exactly the same machine that they use for it.
I think that's an important message we are also trying to give to everyone, that it is not that difficult, and that can sometimes be really useful in.
You just need to convince your lab technician to do it. But if you establish good relationships with the pathologist in the lab, then it should not be a problem. You're not ruining the analyzer by putting urine in there.
Yeah, that's
Flash
what
through at the end anyway. Yeah.
Yeah, that's what we were told. So.
Yeah, it's a problem.
Devlina, you have any question?
I had a question. It may sound a bit ridiculous, but one thing to know that we use indomethacin in children with Bartter syndrome. We know that one mechanism is it decreases the GFR. There are other mechanisms as well. So, sir, like, can we try using indomethacin in a child who is having Fanconi?
So I understand.
Oral
Yeah, so I understand about the potential use of indomethacin in Fanconi syndrome. Is that right? Is that the question? You're freezing, so it's difficult to understand you.
Sorry, Devlina, yeah.
But if that's the question, yes, okay, that's the question. Yes, yes, you can. So it typically also helps to reduce the urine output and to reduce the electrolyte losses. And I see in the chat, can we use ibuprofen? Absolutely. We hardly use indomethacin anymore. At some point, liquid indomethacin was not available in the UK, so everybody got switched to ibuprofen, or we increasingly also use Celecoxib as a selective COX-2 inhibitor. They all work fine. And when Francesco Emma did the analysis of the cystinosis cohort, for instance, the European cystinosis cohort, which was just published, the use of indomethacin was actually associated with better long-term kidney function, a trend for better. It was not significantly different, but it clearly was not worse kidney function. So indicating that the long-term consequences of using these COX inhibitors are apparently not as severe for patients with tubulopathies, and that having better volume status and better perfusion actually in the long term is beneficial for them.
Somebody asked me that whether you can use paracetamol also.
Yes.
So that you would need to ask a pharmacologist. I don't think that paracetamol works as effective on the cyclooxygenase as the cyclooxygenase inhibitors, but that you would have to ask a pharmacologist. I don't think it's as effective, which is also the reason why you don't get acute kidney injury if you have a paracetamol overdose, because it's not inhibiting the inducible COX.
Okay, I think, thank you very much.
I need to go to my next meeting.
Yeah, and we
So,
definitely like to already pre-book you for the future for the electrolytes.
okay.
Thank you very much for
Enjoy your dinner.
attending.
Yeah.
Thank you.
Bye.
Thanks.
And
Bye.
Bye.
thank you to all the participants and our sponsors, Steadfast. Thank you very much. Bye.